Hello everyone, I am Dr. Swathi PM, Fellow in Department of Paediatric Haemato Oncology, Majumdar Shah Medical Center, Narayana Health City, Bangalore.
Hi, I'm Dr. Shobha Badiger. I'm a consultant in the same hospital, Majumdar Shah Medical Center, Narayana Health, Bangalore.
Hi everyone, I am Dr. Ravi Joshi, Associated Consultant in Majumdar Shah Medical Center, Bangalore.
On the event of Thalassemia Day, May 8, 2022, let's have a brief discussion about thalassemia, its awareness and its treatment option. So basically, thalassemia is an inherited blood disorder where the body produces abnormal and low hemoglobin level, where the patient requires repeated blood transfusions. So Dr. Shobha, what is the incidence and what is this thalassemia?
So, like you said, Dr. Swathi, thalassemia is a genetic problem related to blood where the hemoglobin is not normally produced. It is produced, but it is abnormal. And because of its abnormality, the red blood cells will start breaking down in the body. This in turn will result in certain changes in the body like bony changes, which Dr. Ravi will describe in detail. And unlike what the general population believes, thalassemia is quite common, and India has the largest number of thalassemia major in the world. In the entire world, the number of thalassemics are around 240 million, out of which around 1.5 lakh is found in India alone. And every year we have at least around 10 to 15,000 children being born with thalassemia major, which is very sad. And around 1.5 million out of our own population, Indian population is 1.21 billion, and out of which 1.5 million people are found to be carriers, thalassemia carriers. So you can imagine if these carriers continue to produce children, there is 25% chance with every couple having a thalassemia major. So it's quite common, and unfortunately the awareness is very less, and hopefully our brief discussion will bring about some awareness on thalassemia.
Thank you. So, Dr. Ravi, how do we identify the child with thalassemia? What are its symptoms?
Yeah, initially children will be as normal as any other child. Symptoms will start appearing after 5 to 6 months. Parents can notice that the child is little pale, we say, as the hemoglobin will be low, child will be little pale. And parents may notice that the abdomen, the tummy size is increasing gradually over a period of time, 1 to 2 months. And there will be some inactivity because of low hemoglobin. And over a period of time, even facial changes, as Dr. Shobha mentioned, because of, we call it extramedullary hematopoiesis, because of that facial changes, bony changes will keep on coming, like frontal bossing or depressed nasal bridge, crowding of teeth. We call it thalassemia facies. These features will keep on coming over a period of time.
Okay, thank you. So, Dr. Shobha, we know that it's a common problem. So, once the child is diagnosed, how are you going about the treatment? Is there any cure?
Yeah, there is definitely cure, but before that the child will be identified with blood test. A simple complete blood count, it's called, will identify that there is anemia, and then a very simple test called HB electrophoresis will be done, which will kind of confirm that it is thalassemia. Once it is confirmed, children will need, if the child is thalassemia major, will need blood transfusions every 3 to 4 weeks. But this is not curative. It has to be continued lifelong until they receive a curative treatment. And once the child receives around 10 to 12 blood transfusions every month, their iron levels in the body will become abnormally high. And at that time, they will also receive what is called iron chelation, which will remove the excess iron from the body. This is very important because the iron will go and get deposited in various organs and cause a lot of damage to heart, liver, and endocrine glands. So there will be growth retardation. Sometimes in older children, we have even seen diabetes and so many other hormonal problems. So to prevent this, iron chelation becomes very important. In addition to this, nutrition and then vitamin D, calcium supplements will be given to the child. But these are all not curative. They are all something that will bring the child under control. And if the child is transfused regularly and the pre-transfusion HB is maintained at 10, then they will not have all those symptoms over time. They will look like normal children, but it's very difficult to maintain that as a child grows older.
Yeah. Thank you. So we were talking about the cure. Is there any curative option, Dr. Ravi, and what is it? What's its role?
Yeah, definitely. It's a curative. We call it bone marrow transplant. We have done some 1,700 transplants in our institute. We'll have to, for bone marrow transplant, we'll have to choose a donor first. Okay, we basically do a test called HLA typing in the child which is affected, and also the siblings if they are there, and parents HLA typing will do. In case if we hit a sibling as a donor who is a HLA full match, we call it either 10 by 10 or 12 by 12 match. We can offer a bone marrow transplant to the child, which is curative. And most of them, in fact, a few people are worried about the bone marrow transplant as it's an intensive procedure and it may have some complications. Yes. But most of the kids with sibling donor transplant, even with haplo, since last 10 years, haplo outcomes are very good. They do, even if we do transplant with taking parents as donors, they do very well. Most of them, they will do very well.
Thank you. So, Dr. Shobha, anyway, if this disease can be prevented, is there any option of prevention in this?
Yeah, once the child is born with thalassemia, there is no way we can prevent it. The one and only way of preventing is a child being born. We should prevent the child being born with thalassemia, and the way we can do is what is called antenatal screening. Before we do that, if there is already a child with thalassemia major in the family, that child should have a genetic test done and the report should be ready. This is very important because the report takes around 1 month to arrive. And and the couple should have a planned pregnancy, because we need a proper ultrasound age of the pregnancy, and around 9 to 11 weeks of pregnancy, the mother will have a test done on the fetus. It is called chorionic villus sampling or chorionic villus biopsy or amniocentesis. On that fetal sample, test is done, a genetic test is done, and that is matched with the genetic test of the already existing thalassemia major in the family. And that report on the fetus will take again 1 month. And if that report is positive, that is, if that shows that there is thalassemia major, the parents can decide on whether to continue the pregnancy or not, knowing that this child will be born with thalassemia major and will have to require all the treatment that we discussed. If they decide to abort the child, then it has to happen as per the legally recommended time, which is 24 weeks, 20 to 24 weeks. Beyond that, abortion is either illegal or harmful to the mother. So having a planned pregnancy, having a pre-existing genetic report of the child who's already thalassemia, and chorionic villus biopsy on time, and deciding whether to have a baby or not is the only way to prevent. If the other way is, if the couple who are going to get married are aware that this is a genetic disorder and they themselves get tested in the beginning itself with the HB electrophoresis, a very simple blood test. If both of them are thalassemia traits or carriers, then there is a 50% chance that the baby will be born with thalassemia major. If one of them is a thalassemia trait, then there's a very low chance, there is a almost no chance that the baby that will be born will be a thalassemia major. So that is another way. And if the parents are both thalassemia trait, then they can go ahead with this planned pregnancy, chorionic villus biopsy, and other ways to prevent. There is no way we can, if the fetus already has thalassemia major, we cannot medicate and prevent the disease. That is not possible.
Yeah. Thank you. So, Dr. Ravi, we know there's quite a lengthy process. So, for all these treatment options, do these patients get any government or non-government support?
Yes, definitely. In fact, coming to initial part of regular blood transfusions, regular chelation, and regular once in at least a few months, they have to consult a super specialist to see that the things are going fine. There are few hospitals in the state, Karnataka, and also in India, where they cater for regular transfusions. They'll have their own issues as such. For example, for a regular transfusion, you need fresh blood first. Okay, that too PRBC, packed red blood cells, we say. That too within 1 to 2 weeks fresh blood we should get, first thing. Second, in case if they can provide a WBC filter, we say, white blood cell filter, we'll have to remove some white WBCs from the product so that child will not have any complications later in life. That WBC filters, and if at all, if facilities are available, we prefer irradiation also of the PRBC product. few of these facilities are available at government hospitals, and most of the kids, say some 90% of the thalassemia major kids, they go to government hospitals to take transfusions because it's a lifelong requirement and family has to spend a lot of money on to care for this kid. This makes some 90% of the stuff. When we are talking about bone marrow transplants, definitely there are a few states in India, as we were discussing, Tamil Nadu, Andhra, Assam, Odisha, Chhattisgarh. There are many other states who are supporting thalassemia major kids to undergo bone marrow transplant. That support is not available in Karnataka as such. From central government, there are a few schemes, mainly through Coal India. Central government sponsors to kids undergo bone marrow transplant who have a matched sibling donor, who is a fully matched sibling donor. So they sponsor such transplants. And also there are many NGOs which we are associated with. There are many platforms from where we can raise some money for the kids who are fit for transplants, and to make sure that they'll get cured. In fact, the awareness regarding BMT, bone marrow transplant, as such is low. And even if someone counsels families, it will take more counseling, and also it will take more time for them to believe that such facility is available. And also we should try our best in our lifetime at least to make sure that we'll prevent thalassemia major from happening, and also try to push for as many transplants as possible through government, and also through support of NGOs.
We also have Prime Minister Fund. And in fact, the transplant has to be planned the day the diagnosis is made.
Yes.
The moment the diagnosis is made, they should be told about transplantation and the benefits. And in our own center, like any other Western countries, we have very good outcome, both with matched sibling donor as well as haplotransplant. Almost with matched sibling donor, we have 80 to 90% children are cured for life. And they won't require any more blood transfusions or iron chelations throughout their life. With haplotransplant, we have 60-70% cure rates, which is very good. So this has to be planned as early as possible. Any child above 7 years will already have a lot of complications, iron deposit everywhere. So as early as possible, the ideal age would be 1.5 years and above. Below 7 years, earlier the better. Yeah.
Thank you, Dr. Shobha. Thank you, Dr. Ravi. I think this brief discussion has solved many of the common doubts which everyone has, and it has provided little more awareness, and more people will be willing for the curative option. They know how to manage they know what is required, what has to be done. Thank you.
Thank you.